Hello friends, this is Dr. Tavleen. Today we'll discuss what are the high risk pregnancies. We'll be talking about very common features which everybody can know about. You don't have to go very much into detail to know about it. Firstly, when you're pregnant, and what is your sense of well-being? Are you having that sense of well-being or not? Are you feeling yourself? Are you feeling too much lethargic, or you are not feeling like doing anything? You feel too much sleepy? Simple thing is just get your HB done, and just see whether it is how much is the HB, and let your doctor help you decide whether it is mild, moderate, or severe type of anemia. Whatever type of anemia it is, depending upon gestation, what time is of your pregnancy, whether it is first month, second month, third month, or ninth month. Depending on that, the supplementation can be given. If it is in first trimester, we'll definitely try to give oral supplementation. Iron ascorbate is the most commonly that we have been using, and it's a supplementation given you twice a day, given for 20 days, 1 month, and see whether the HB is increasing, because we know it will take about 1 week minimum for our body to start responding to iron supplementation that we are giving. But this most important thing is the patient will be able to digest the oral iron or not, because some patients do not digest it well. They start having a lot of vomiting and a lot of nauseous feeling. Even maybe they can also present with saying that I have gastritis, I'm having pain in my upper abdomen, and it is probably when I started with my iron supplementation. So this may be an issue which we have to deal with. So in these patients, we'll have to give parenteral iron. It can be intramuscular, or it can be the iron sucrose that we give in a drip. We put ampules, 2 ampules in 100 ml NS, and that is given every alternate day to the patient. We have to first check that the patient is intolerant to the oral iron, or she's not compliant. Sometimes compliance also becomes an issue. So this way we can manage the HB, which is low HB in pregnancy. Second thing is what is the blood pressure of the patient. Blood pressure of the patient is very important, because what I generally tell my patient is, if your BP is less in pregnancy, you should be happy about it, because in BP in pregnancy your BP should not increase. It's not a good thing to happen. The BP has to fall. If the BP falls, that is something very good and you should be thankful about. So it probably happens about 20 weeks of pregnancy, you can say. Probably we'll say after 5 months, that the patient says that I'm always having low BP. It's like 90, 60 or 170, like that. So it's good, nothing to worry about it. But what if the blood pressure starts rising? The patient says, I've been having good BP 170 or 160 for the first 5 months. Now all of a sudden my blood pressure started increasing. So how to tackle the situation? You have to first counsel them, explain them what is the reason, what is the pathogenesis of this, why has this happened. In simple language, I'll explain you what happens is, when in pregnancy the placenta and the embryo and the fetus is developing, what happens is the mother's body makes certain changes so that she has vessels which are wide and which are very spacious, you can say that, so that good amount of blood goes to the baby. If this will happen, only then the baby will be healthy, making good amount of urine output, having good nutrition, having good amount of fluid around it, which everybody knows. So this becomes the reason why we want the blood pressure to fall. Only when the vessels will be much dilated, the BP will fall. But if the vessels are very thin and very constricted, that case the blood pressure will increase. So in mother, we are just seeing that blood pressure is getting increased, but it will be affecting the baby as well. The baby won't be able to grow well, because he won't be getting all that nutrition which he was supposed to be getting from the mother. So that is the thing that will be tackled by your gynecologist, putting you on oral antihypertensive medicines. And if the best medication that we give is tablet labetalol, which is very much safe in pregnancy, and the dose will depend upon how much your blood pressure is rising, whether twice daily dose is required. 100 milligram, we start off with 100 milligram twice daily. If the BP is not getting control, then maybe 100 TDS or 200 TDS, and total dose 1200 milligram can be given. So next thing comes, when you've checked your HB, when you check your hemoglobin, you are also dealing with your pulse rate. You will always have high blood pressure. You will have pulse rate, high pulse rate. So you will be dealt with. When you get iron supplementation, you'll be feeling better. Second thing is when you have blood pressure, and you'll be dealing with it. Next comes, what is your thyroid profile. You definitely should get your thyroid profile done, because if the thyroid is deranged in pregnancy, firstly it can affect your pregnancy as well. Okay, you might not be able to conceive, or you might not be able to proceed much well with your pregnancy. So when you get your thyroid profile checked, and whatever is the alteration, that will be dealt by your doctor. And what is the baseline that has to be there? For the first 3 months, it should be like 2.5. For the next 3 months, 3, and the next 3 months again, 7th, 8th, and 9th month against 3.